welcome. This is TDT Live. I am Stacey Ann Providence. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago, and we're bringing you live coverage on TDT, Talk City 91.1 FM, Suite 100.1 FM, Next 99.1 FM, and on Facebook at TDT Live Online. We go now to the Manager of Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning and welcome to the Ministry of Health's virtual media conference on the national COVID-19 response. The members of today's panel are Dr. Roshan Parasram, Chief Medical Officer, Dr. Avery Hines, Technical Director of the Epidemiology Division, and Mr. Roshan Siram Singh, Geographic Information Systems Manager in the Epidemiology Division at the Ministry of Health. I'm Candice Alcantara, Manager of Corporate Communication at the Ministry, and I will moderate this virtual conference. First up this morning with the clinical update is the Chief Medical Officer.
Hi, good morning. Thank you, Ms. Alcantara. Morning to Dr. Hines, Mr. Roshan Siram Singh from the GIS unit, members of the media, members of the viewing and listening public. So I'll if I can have the slide up this morning with the dashboard. I'm just going to go into a little more explanation as it relates to the clinical update this morning. First slide, please. Okay. So I'll talk you through it and then we can get it up a little later. So as of yesterday at 4 p.m., 3rd of November, we would have had a total of 33,383 tests submitted in the public sector. In the private sector, as of the 30th of October, 20,301, giving us a total for public and private 53,684. Over the period 12th of March to present, we have a total of 5,754 positive persons. Total recovered persons are now 4,929. Total active cases 715. Number of deaths stand at 110. And the number of new positives over the last 24 hours reported are 50, 6 of which would have been from our repatriation efforts. In terms of our hospital, we have 49 persons in hospital at this time. In the step-down facilities, there are 32 persons. At the quarantine sites, 227. And in terms of our home isolation, we now have 584. Just a little more detail into our hospitals. So at the Couva Hospital and Multi-Training Facility, we have 32 persons, 3 of which are in ICU, no persons in HDU at this time. At the Cora facility, 14 individuals. At the Augustus Long, there's 1 person in ICU, and at the Scarborough Regional Hospital at the Fort, there are 2 persons. With regards to our step-down transition facilities, 32 persons in total. At the Claxton Bay Correctional Facility, there are 18 persons, Uwe Debe, 13, and in Tobago, there's 1 person. With regards to our state-supervised and state facilities for quarantine of repatriated persons, we have 25 persons at the Chancellor Hotel, 32 at Cascadia Hotel, Home of Football 42, Regent Star 9, Paria Suite 68, UTT Valsine Campus 16, UE Freedom Hall 35, giving us a total of 227. Ms. Alcantara, I think that's the end of my clinical update for this morning.
Thank you very much, CMO. And we go now to Dr. Hines and Mr. Siram Singh, who will present some epidemiological information which will zone in on some of the areas where we see the most COVID-19 cases. We go to Dr. Hines first and then to Mr. Siram Singh.
Thank you, Ms. Alcantara. This morning we're going to change the format a little bit and expand a little on the geographic component of our epidemiologic update. As such, my component giving the demographics is going to be a little briefer. So if we can go to the first slide, we are looking just at the continuation of the data. Next slide. That we've been presenting using the EPI curve. That is the curve, next slide, that shows the number of cases by the date on which the case presented for sample collection. Next slide, please. So as we can see, over the time period from July through August and September into October, now the start of November, we have had that peak at the sort of the end of August and moved slowly downward through the month of September to have almost a plateau, almost a sort of a flat line, constant number of individuals coming in, which right now hovers around 27 to 30 per day on average. And that is what we are speaking about when we speak about that plateau, that daily level that we are still attempting to reduce by asking people to maintain, to adhere to continue to follow and to practice all of the preventive public health measures, because you need that line to go down as opposed to just being flat. Next slide, please. Looking at the demographics, looking at the age and sex distribution of the cases, we do see that the same pattern is being maintained. Slightly more men than women, so males are 52.7% of the total COVID cases diagnosed. And of those individuals, the people in the 25 to 49-year-old age group occupy or take up nearly 55% of that total. So more than half of the COVID-19 positives have been in that 25 to 49-year-old age group. Next slide. With respect to the deaths from COVID-19, we have seen a pattern that has maintained itself, where 3/4 of the individuals who have passed on have been men. And the majority of them have been over the age of 60. Again, the overwhelming majority have had some sort of pre-existing condition. We have seen a couple deaths in the under 50 age group, and in fact, in the under 25 age group in a couple of cases. Again, individuals with pre-existing conditions that we are using the opportunity to remind in all persons, whether they know if you have a pre-existing condition or not, your age does not protect you. Just being young does not protect you from having an adverse outcome. So as we extend condolences to the families of those who have passed on, we also want to reiterate that warning to the general population that regardless of age, everyone should take COVID-19 seriously and take all the measures that can be taken to reduce your risk of becoming infected. Next slide. Now with this, I'm going to turn you over to Mr. Roshan Siram Singh, who is going to take a closer look at and give a little more detail on the geographic information systems side of things. He will continue with the next set of slides.
Thank you very much, Dr. Hines. CMO, Dr. Parasram, Technical Director, Epidemiology Division. Dr. Hines, Ms. Alcantara, our viewing and listening audience today, good morning. As we proceed to the next slide, we will be looking at one of the dashboards that we've created for our internal use within the ministry. Key to note on this dashboard is on the left-hand side, we have the statistics which are presented on a daily basis on our press releases. However, in addition to that, we also have a mapping component and a chart component. The chart represents an age-sex pyramid, and we also have additional charts which are on the other tabs, which will not be presented in this particular image. However, the mapping component provides us with an idea of what the case rates are per 10,000 per county. Looking at that particular map as we go on to the next slide, we would see what the case rates per county look like. It's interesting to note that the case rates per county does not necessarily align with the total number of cases per county. And I'll draw your attention to St. Andrews and David. Here we have one of the higher rates across the country. However, when looking at the total number of cases per county, we see that there are 3 counties of particular interest. St. George Central, Caroni, and Victoria are 3 counties which require additional attention. As we move on to the other slide, we'll see what the distribution of cases look like in this map. We see that there's a continued high number of cases along the east-west corridor and in various highly populated segments such as San Fernando. And the same information used to generate this map was used to generate the graduated symbols map, which we see next. This graduated symbols map, as we've seen throughout the press conferences, show the spread of cases across the county. I'll backtrack a minute and share with you how we get to this point. When the laboratory confirms a case, that information comes to the epidemiology division, a unique ID is assigned, and the case is mapped onto the GIS using a Survey 123 form. This form standardizes the data entry process. Once the cases have been entered, we aggregate the cases and conduct analyses at different output levels, be it the county or the community. In this case, we see the cases per community. As mentioned earlier, there are 3 areas of concern, 3 counties which we are looking at: St. George Central, Caroni, and Victoria. As we move forward, we'd see this slide of the entire country, however, in which we look at the cases for the last 2 weeks. So we introduce the temporal component, maximizing on the abilities of the software that we use to really analyze and better understand the spread of cases. As we move to the next slide, we see what exists in County St. George Central, one of the counties which is being looked at. Here we see what the spread of the cases look like at a community level within the county. And looking at the data at this level really allows us to engage in strategic resource allocations and evidence-based decision-making. Much like St. George Central, we have done similar maps and analyses for County Caroni, which we see next, as well as County Victoria. As we move on, we'll see these counties. Here's County Caroni, and we move on to County Victoria. It is important to know the spread of the cases across the counties, and we see that there's a preference, of course, for the densely populated areas, the higher populations. As we move on to the next slide, we would like to introduce this morning a facilities finder, a web application which we've developed to be used by the public that will help us to facilitate easy identification and location of facilities which are close to us. This is thinking forward. We are preparing for the future. We are harnessing the technology to really prepare for future work as we look at vaccination and as we look at various initiatives which will be coming forward in the future. Here we see the spread of facilities across the country, and as we move to the next slide, we see that it's quite easy to use the software to look at facilities based on your location. Using your mobile device, using the GPS component and capabilities of the device, you can set your location and identify all facilities within a certain distance. This would allow us, therefore, in the future to allow people to better understand and access health centers within their areas. Thank you very much.
Thank you very much, Mr. Siram Singh. And we go back to the Chief Medical Officer, who will give us a little insight into the new dashboard and make sure that we all understand and are all on the same page.
Okay. So can we pull it up? Right. So basically what we're looking at, and I just wanted to reiterate what we had said in the early days when we had just started the dashboard, probably about a month ago. So we're looking at the top total persons tested, which we gave. Of course, it really deals with what we have said before as unique patients tested. It doesn't include repeats. So usually once a week on a Monday, I will present the total number of public sector and private sector as we get updates from the private sector on a Friday afternoon, and that is presented on the Monday. If you go down to your left, total recovered patients are usually persons that have recovered from home isolation, from our step-down facilities, as well as from our hospitals. The total active, that gives us the total active cases. If you take that total and you subtract it from the total positive cases from 12th of March to present, of course the total number of deaths are there, and the total hospitalized patients. And of course the distinction being made between hospitalized patients, step-down, quarantine, tells you, and home isolation, tells you at a glance the level of care that people are accessing at any one point in time. But what I wanted to pay a little attention to, and what has been in the media for a couple of days, is the new positive cases reported in the last 24 hours. So 2 days ago, we would have had 0 cases reported in the last 24 hours. I believe it was Monday afternoon. So there was a lot of media chatter going on about why we had 0. And, you know, it is not that we had no cases of COVID-19 in Trinidad and Tobago. We had active cases. We had over 700 active cases. As you know, we had cases in the hospital as well. What it basically means, as we get reports of positives, and the reports usually come from either the private sector or through the National Trinidad Public Health Lab, that comes directly to myself by email to report into the 4 p.m. update. So it happens once a day now, and it gives an idea of what happens for the previous 24 hours. Usually on a Sunday and a Saturday as well, a lot of the health centers, the sites for persons to get swabs are closed. And we find, especially on a Sunday, a lot of the turnout for persons are lower. The only sites they can access are the accident and emergency departments in the major hospitals. So for this particular 24-hour period where we had zero being reported in terms of zero positives. Yes, we did do some tests. However, they would have been lower than the other days, one. And of course, none of them came back as being positive during that 24-hour period. As simple as that. It doesn't mean that there's no COVID in Trinidad and Tobago. And it does not necessarily mean that there was a significant decrease in the number of cases. We will continue to use the weekly average as our gauge as to what is happening, and that's why we use an entire week or sometimes even 14 days prior to give us an indication of what the patterns and the trajectory of the disease looks like, not any particular day. So, Ms. Alcantara, just to give some clarity to that particular issue.
Thank you very much, CMO. And we go into the question and answer segment of this media conference now. Media representatives, please indicate your name and your media house before posing your question. We ask for no more than 2 brief questions. Please, if time allows, of course, we will accept additional questions from the media. And we begin this morning with questions from CNC3 of Guardian Media Limited.
Hi, good morning, everyone. Rashad Khan, Guardian Media Limited. I have my 2 questions to the Chief Medical Officer, but I'll ask them one and then ask the other one after I got a response, right? So, CMO, I'm glad that you brought up Monday's results. Would you be able to say how many samples were tested over the weekend period? Right. And within that, is the ministry taking any steps to give us real-time results or real-time positive cases instead of some with that delay and then some here and some there and that kind of thing?
Okay, so definitely at one of the sites we had at least 20 cases coming in from the North Central Regional during that particular period. I don't know how many we would have had from the Trinidad Public Health Lab side of it, which caters for the rest of the country at this point in time. I just need to get some clarity on your second part of the question. We provide press updates every day at 4 p.m. You know, in the past, we would have done that 3 times a day. I don't think what we get at 4 p.m. in terms of the update comes directly as an email from the Trinidad Public Health Lab to myself and the Corporate Communication Unit. So as soon as we get those, we publish it on a daily basis once a day. I don't know how we can facilitate more than once a day, aside from going back to 2 or 3 times a day with regards to a press release, in terms of real-time data to the press. You want to clarify that point?
Yes, I will. I meant as in there's usually that 2-day period which comes in the asterisk at the bottom of the update, which says these samples were taken from about 2 or 3 days ago, and that's the results that we are seeing. But what I meant is, could we expect at any point in time to be able to see that, okay, these cases which we are seeing reported by the ministry is from the last 24 hours?
Right. So generally speaking, I think the 2 to 3 day is international best practice for reporting of tests to the press or to even any other agency, PAHO, etc. So it is best practice. As you know, there's a process that it takes from the time someone is sampled to the time you generate a report. It includes a validation process even after the test is done. What we have as a finite time frame is from the time that test actually reaches to the lab to the time that test result is validated and generated, 24 to 48 hours, which is internationally very good. It is something that CAFA has said in a media release as well, that they will stick to 24 to 48 hours, and we are guaranteeing, for now anyway, that we can maintain 24 to 48 hours within our lab system as well. But to say that we do get tests, for example, a test may be done at one institution, it's run, and the patient has a result within a few hours, those who coming to accident and emergency, for example. But that will be published as a group when we actually, it will be catered for. However, the caveat that we put on the bottom are for the outliers of the process. So it can be anywhere between 24 and 48 hours. Some of them are much less. Some of them linger to 48 hours, depending on the facility that it comes from, the distance, and all of those variables. So we will continue to maintain 24 to 72 hours in terms of our reporting timeline.
Thank you very much, CMO. Rashad, you're throwing in another one? Okay. Rashad has point A, B, and C.
It's like one of those SCA tests on them. Okay, the second question I had for you, CMO. Did you get back the autopsy results from the person who would have died on the repatriation flight?
No, I didn't get it myself as yet. No.
Okay, great. Thank you very much. We go to AZP News, please.
Good morning. Hi, good morning. Priya Bihari, azpnews.com. CMO, you basically answered my question because I was going to ask again about the reporting numbers. So is it, just to clarify, is it that you think that on the weekends the numbers are lower, so therefore maybe Monday, Tuesday we will have lower numbers? And why you think the reason for that? And secondly, in terms of the contact tracing, has sufficient been done now to say, and can you say what causes the major cases of COVID-19 now? Is it at people at bars, or is it community spread, or is it into the country? Thank you.
Okay, so the lower numbers, as we described before, I think myself, Dr. Nandram would have mentioned as well when he did his update a little while ago, that generally speaking, the trend has been we have decreased testing on the weekend just because a majority of the facilities that do testing are actually closed on a weekend, on Saturday and Sunday. So all the health centers, we have over 100 facilities that are actually closed during that time. So you do see a decrease in the number of tests that are conducted over the weekend. And of course, based on that proportion, you see a reduction in the number of positives that we see over a weekend period. Mondays and Tuesdays, by Tuesday, Wednesday of every week, you get back to some level of normalcy. And again, that's why we use a 7-day trend to give us an idea of the average, because it sort of averages out over the entire week based on the presentation of people with viral illnesses. Your second question, just remind me, Priya.
What you think is the major cause of people contracting the COVID-19?
So I don't want to hazard
is it via a community spread, etc.?
Yeah, so we are still at community spread. I don't want to hazard a guess as to which area is, most active in terms of contact tracing. Any particular group has not really stood out over the last week or so in terms of our cases coming back as positive. At the county levels, the CMOHs are actively pursuing to see if there's any clustering in any particular locality or coming from any particular source. So once we have any definitive confirmation of any particular area of the economy being a driver, we will let the press know.
Thank you. And we go now to Astronaut News, please.
Thank you very kindly, Ms. Alcantara, and a very pleasant good morning to the members of this esteemed panel. Given the fact that the fast ferries, passenger ferries that travel between Trinidad and Tobago on a daily basis, to the best of my awareness, the voyage is about 2.5 to 3 hours, and they have to be in there like half an hour before and so on. So give it about 3.5 hours there on the vessel. Now, the capacity is 50%, and they cannot run from the vessel during the voyage. They have to remain put. What, therefore, is the rationale for that 50%, 4 hours together, as opposed to 1 hour for religious bodies? In the light of what happens vis-a-vis the fast ferries, could it be reasonable to expect that the medical experts can recommend to the political directorate that we can appreciate the time from 1 hour to, let's say, 1.5 hours, 2 hours, in the light of what happens on a daily basis with the fast ferries going between Tobago and Trinidad? Thank you.
Thank you. And Dr. Hines, I think we'll take this question.
Okay, thank you for the question. It's an interesting comparison that I would like to maybe look at in a little more detail. The comparison you're making is between individuals generally seated, not having prolonged conversations, not having singing, and not being expected to interact and fellowship, etc., on a vessel, basically minding their business and going from point A to point B, masked. And you're comparing that with a situation in which there is prolonged singing, talking, there is some expectation of interaction. And what we're actually attempting to do by minimizing the duration of exposure in one situation and minimizing the occupancy in another situation is we're trying to find the best way to reduce risk in each situation. We cannot modify the time frame that it takes to get from Trinidad to Tobago by ferry. So it's not one of the options at our disposal. We therefore only have the option to reduce the occupancy and hope that that helps to reduce the risk. Where we can modify additional things to reduce risk, we put that in. We put those considerations in, so that in whichever situation people find themselves congregated, we still have minimized the risk of transmission, given the fact that we're still having activity with congregation taking place. I'm hoping that helps to clarify it a bit.
Thank you very much, Dr. Hines. I think we have a second question. So we're back to Astronaut News, please, with a second question.
Thank you kindly, Ms. Alcantara. It's not really much of a second question. It's more like a follow-up to the answer that the very learned Dr. Hines gave. Now, I am saying, as one who is a practitioner in religion, I can tell you, in respect of the liturgy, people will sing with their masks on. There is not much interaction. There is physical distancing. The chatting and fellowshipping is very minimal. And I want an in-depth study to be done relative to the worship session, so that the 1 hour is really inadequate in the context of that fast ferry situation. That is the basis on which I'm applying my argument. And the point that you have made, Dr. Hines, with the greatest of respect, is not very much different in respect, because we don't do much interaction. The interaction is done on Zoom, it is done on the phone, and not while we are in the physical presence of each other. In those circumstances, as I conclude, I hereby most humbly request that further consideration will be given to give the religious bodies another half an hour to 2 hours maximum. This is my humble request in the context of the situation with the fast ferries between Tobago and Trinidad.
Okay, so as I said before, the point that we're making is risk reduction, and there have actually been papers that have demonstrated transmission in church service settings, the indoor setting, the circulation of air, again, the singing. I like the fact that he pointed out that a lot of this is being done by Zoom. We want to encourage that. We want to encourage the remote access platforms being utilized for any place where congregation physically can be replaced by congregation electronically. I also want to point out that this table, the panel here, is not the panel that makes a decision on the length of the service. We make recommendations on risk mitigation measures across the board, and then those recommendations are considered and implemented according to the decisions taken by the Prime Minister. And we can't, at this level, make any recommendation or make any promise that we will have that modified. Nonetheless, we do take your point on board, and we hope that you understand our point with regard to limiting risk in the best way that we can in the varying situations.
Thank you very much, Dr. Hines. And we go now to TV6, please.
Morning, everyone. Urvashi from TV6. Dr. Parasram, you said a short while ago, you rightfully said that the virus is still here. And regardless of how many we have, it's still there, it's still being spread. Given that measures, we are going into the second week of a further relaxation of measures. Are you expecting any sort of surge? What exactly are you expecting, and how are you preparing for that, given that we would want to move from community down to cluster? That's question one. Question two, we're still seeing that there's about 1 death every 2 to 3 days, with a weekly daily average of about 25 per day. How do you feel about that? How does that look from your perspective? Thank you.
Okay, so generally speaking, what we have noticed, and when you look at the trends looking backwards in terms of the epidemic in the second phase, and we look retrospectively at the spikes we have seen related to change in human behavior. For example, when we have seen an increase in congregation without mask wearing, we have seen, by way of spike, that increase occurring 14 to 28 days after whatever public health event has occurred. So we are looking at 14 days, just 14 days ending Friday, to be basically a sort of starting block if the reopening had any effect in terms of the way you would expect a spike. All right. We are hoping that with, of course, adherence to the guidelines, that spike doesn't occur. Really, with the masking, the universal masking that is there as part of the legislation, I hope that has gone a long way to prevent any spread from person to person. And as you noted, in terms of opening the economy, we have taken the careful steps to prevent any, at least in the public spaces, prevent any gathering occurring where persons cannot wear a mask. So we have gathering that may be occurring for limited periods of time, but we are ensuring that persons are able to wear a mask. Hence the reason, as you would have noted, for cinemas, for example, we ask that you can go ahead and use the cinemas, but you can't wear a mask. You can't eat during the time you're there, just for the sole purpose of being able to wear a mask throughout that whole viewing experience, so that you decrease the risk of transmission. When you look at the number of deaths, you asked about our procedures. Our procedures have always been the same to mitigate risk. Of course, creating that public health tier at the national level, ensuring there's mask wearing, ensuring there's social distance and everything else that goes along with it. But of course, the premise of containment has always been, with community spread, to test as quickly as we can to ensure that we are picking up all the cases of viral illness that are indeed COVID-19, isolating those persons either at home, in a step-down facility, or at hospitals, so that we prevent spread outward to the population, ensuring that they stay there. And of course, treating appropriately to ensure that their disease does come out with the best possible outcome, which leads you into the question regarding the deaths. As I said, our death rate is hovering somewhere between 1.77. A couple of weeks ago, there's a slight change. It goes up a little bit, sometimes about 1.8. So let us look at it as a rough average, about 2 cases of death per 100 persons that contract the virus. The lower our numbers are, therefore, the lower the number of deaths based on what we have seen in the past. So we want to get our numbers as low as we possibly can to prevent any further deaths from this particular illness. But for every 100 cases, we expect to see at least roughly 2 deaths occurring going forward.
Thank you very much. And we go to Newsday next, please.
Good morning to those on the panel. Paula Lindo here from the Newsday. So, Dr. Parasram, my first question is, could you give us an update on the situation with the Arima Racing Club? I know that the Trade and Industry Minister would have submitted a report to the Health Ministry. Not sure if it would have come across your desk as yet. And second, what numbers are you looking at in terms of allowing more reopening to happen, seeing as how our number of active positive cases has been declining for a while? Thank you.
Okay, so nothing, no such report has come across my desk as it relates to that first matter, Arima Racing Club. So I haven't received anything regarding that from Ministry of Trade or the Ministry of Health. There's no magic number. I want to say there's no magic number for advising to reopen any part of the economy from a health perspective. We're really looking at, we have to look at the overall situation. We do take into consideration the number of cases per day. Of course, we look at our mortality rate, and expectedly, as I just explained to Ravashi, we expect to have 2 deaths per 100 cases that we have, and we have to be mindful of that. The issue that we are seeing is, of course, we are having unwanted deaths, and we will do everything in our power from a health perspective to prevent that from happening. Again, we are trying to keep the curve as flat as possible so that our health system is not overwhelmed at any time. We're actually in a good place with regards to our hospital, with 49 persons being in the hospital system at this point in time, which is fairly good by way of capacity. So the nurses and the physicians, they are getting a much needed break from the spike that we would have seen in August and September. So there's no magic number, for one, and we have, the majority of the economy is open. Restaurants and bars are able to sell their goods as well, although notwithstanding they can't do in-house dining for the reasons that we said before. Of course, if you're going in to do in-house dining, you have to take off your mask, and it's something that we have been dissuading persons from doing, because mask wearing has proven to be, across the world, a very effective public health measure to decrease the risk of spread in the population. So when we meet with the Honorable Prime Minister, we would make our recommendations as per usual, And of course, he will make the ultimate decision on Saturday as to what happens from there on in.
Thank you very much. And we go now to Express for 2 brief questions.
Good morning, everyone, all. I did want to piggyback on something that Urvashi asked in terms of the surge, because around the time of elections, we saw a surge, but there was also a last lap on the beach, and that was blamed at the time. Now, I know there's no vouching day to day for how much people are adhering to the public regulation, the guidelines, sorry, and that would really be told by the numbers later on. So CMO, again to ask if you're expecting a surge, but also in the context of the beaches specifically, if that might again be blamed if there is a surge. Also, if there's anything happening with dengue and swine flu, any update on those figures? Are we seeing any of that at all during this season? Thank you.
So in terms of, we're not going to blame anything. What we do is we do contact tracing to determine if we do see clusters of cases occurring in any particular geographic location. We have to take a proper history from those individuals to determine what sort of events or singular events they may have participated in that would have led to a particular increase in number of cases. But we hope that persons would abide by the public health guidelines, wear your mask and social distance as best as you can. And most importantly, we have been getting complaints of persons going to work, going to different places, for example, the gyms, as well as supermarkets while they are ill. And we want to dissuade persons from doing so. It is a critical public health measure that we have to take going forward. If you are ill, have any of the signs and symptoms, you stay at home. So we're not going to blame anyone. It's not a matter of blaming, it's a matter of attributing the cases based on a medical history and based on geographic spread to any particular event. Regarding dengue, what we have so far, I believe we have 44 suspected cases for the year, 1 confirmed case. When we go back historically to last few years, last year we would have had just around 300 plus cases of suspected cases of dengue. So for this year, we have had the lowest number of dengue cases, I would say going back almost a decade in terms of the number of dengue cases we would have had suspected. If you go back 5 years or so ago, we would have been hyper-endemic, where we had an average of 5,000 to 6,000 cases of dengue in Trinidad, which sort of started to subside around 2016 to 17, where we got into a very good position, having less than, I would say, 1,000 cases each year. Last year 300, this year 44 so far. So it's been a very good year as it relates to dengue in particular. With regards to influenza, I think the public health measures that we have put in place have borne fruit with regards to influenza as well. So basically we're seeing a reduction in the number of influenza cases that we are seeing as well for this year. I don't have the exact figure, but I think we have around 33, 34 suspected cases so far. There have been 6 influenza confirmed cases for the year. That would include some of last season. So that's the data and the update for influenza as well as dengue.
Thank you very much. And CL Communications, we're ready for your questions now, please.
Good morning, Natalie Singh, CL Communications. I wanted to find out one thing regarding young people at the start of the academic year this year. You spoke to young people, the numbers are not up to par when it comes to those being immunized. I was just wondering what the numbers are looking at when it comes to young people being immunized, and are you still seeing trends of people being wary to go to health institutions because they are afraid of contracting the COVID-19 virus? And then secondly, do you worried about the St. George, Central, Carney, and Victoria counties? What is happening correct in the other counties that is not happening in these 3 counties? Thanks.
Right. So in terms of the immunization schedule, I don't know if you're speaking about the normal immunization schedule that is required for children under 5. So in terms of those numbers, they have been comparative in terms of the previous year's number of figures for various illnesses. What we would like to see with regards to, and what we're seeing a little drop off in, is probably measles, mumps and rubella, especially for the year 1 shot. And we are asking parents to be to actually make the effort to have your children immunized as they should. what has happened as well, because people are out of school, they are not doing that final immunization as readily, because it is something that is a preamble to physical school, to going to school. That's something you have to submit to your schools. So what has happened this year, which was peculiar, is that coming before September, people have delayed that immunization, knowing that they would not have to physically go to school for that semester. So we're asking, although you don't have to physically go to school, that you complete your immunization schedule for those 4.5 year old, which is your final immunization, and don't delay just because you don't have to go to school. So we are seeing a little fall off by way of that. So we are asking persons to come in as quickly as you can and have that done, although there's not face-to-face classes occurring at this point. Dr. Hines will go into the second part of the question.
Okay, thank you for that, CMO. With respect to the counties that we highlighted, what we really highlighted was just the counties that had the largest numbers of cases, new cases, within the last 2 weeks. It is not really to say that something different is happening in these counties as opposed to the other counties, but there's a range of numbers that you will see from one county to another, and those three had the largest. We also want to point out that those three counties are the ones that are fairly urbanized in large part. There are lots of opportunities for individuals to mix and to gather. And because of that, we want to take the opportunity to reiterate, not just to people living in those counties, but to everyone, that while we gather, while we move around a little more, while there's a little more activity, that we have to take extra care to ensure that we are wearing our masks properly, that we are washing our hands adequately, that we're not going out when we're ill. And when we say wear the mask properly, we're seeing a lot of masks being worn under the nose. The nose sticking out. The nose is part of your respiratory system. It's connected to your lungs, and therefore we would like to have that covered as well when we're wearing the mask. Cover all the holes in your face, because we want to reduce the spewing of respiratory droplets as we walk about. So just not losing some of the rigidity with which we follow these rules is going to help. So it's not so much that something particular is happening or not happening in those counties, but there's a lot of urbanization, there's a lot of movement, and we want to encourage everyone across the board. These public health measures that we've been advocating are the ones that are going to help us to continue to relax measures with some measure of safety still being maintained. So thank you for the question.
Thank you, Dr. Hines. And just a reminder to our media representatives that Mr. Siram Singh is also here, our GIS manager. And we go to a follow-up question from CNC3, please.
Hi, thanks again. Dr. Parasram, has the Ministry of Health changed its policy on that negative test for people to return to work? Because I'm seeing that some places within the public sector are asking for that negative test for employees to return to work.
Yeah, so we have changed our discharge policy quite a while ago. So we have gone away from a diagnostic discharge criteria to a clinical criteria, as you know. Just to reiterate what we are doing. So persons who have symptoms, we are looking for 10 days plus 3 days asymptomatic, meaning you have no fever or respiratory symptoms. And then we add additional 7 days to it, giving you roughly about 20 days in terms of quarantine. Once you get through that period, you are issued, if you are ill that is, you are issued a letter from the CMOH office saying that you are fit to go out to duty, which should suffice for the employers. If you are asymptomatic, we usually do 10 days from the date of onset, date of your swab, which is positive, plus 3 days, plus your additional 7 days as required. And again, a letter will be issued from the CMOH to go to your employers, but there's no negative swab that is required, again, from the Ministry of Health to discharge one from a COVID positive environment at this time.
Thank you. And now a follow-up question from TV6, please.
Okay, unmute. So, Dr. Parasram, I'm not sure if you would have seen it. If you watched TV6, you would have, but there was a video shared. It appeared to be an immigrant climbing off a little boat at the waterfront onto Trinidad. And given our position now in terms of abating the spread of the virus, I remember at the beginning of phase 2, sometime in July, we would have had what you described as an induced case. As the chief medical officer, how concerned are you still about the threat of illegal immigration on the spread of the virus? And have you communicated that concern to authorities? Thank you.
So being in this part of the world, I think we share our concern of illegal immigrants. We saw it with malaria many years ago, that there was a change in the trend that we were seeing in terms of imported malaria occurring in Trinidad and Tobago. What we had seen maybe about 6 or 7 years ago is that predominantly the cases of malaria that we were importing into Trinidad were predominantly from Guyana, India, and Africa. About 6 or 7 years ago, we saw a trend that changed to the majority of imported cases that we started to have was actually from Venezuela and that area of South America. So it is not specific to COVID-19, but we are so close to other territories. We are virtually 7 miles away from those areas. Persons can come quickly between us and them. We see it happen with other CARICOM states, for example, Guyana, which shares a land border with those territories, and persons can actually get across. So it is a continuing issue. It is an issue of migration more than COVID-19 for malaria, for I would say measles, mumps, rubella. Any disease that is predominant in that particular part of the world will, of course, with its migrants come across. We are cognizant of the fact beyond COVID-19 that we have to look for other diseases coming up, yellow fever, measles, mumps, and rubella, things like malaria, HIV. We're looking at Chagas disease as well. So it is not only a COVID-19 issue, it is a migrant issue. And yes, it has been shared in my interministerial committee with my colleagues. There is an interministerial committee that sits related to malaria that speaks about it and has spoken about it for a number of years. We do share the information that we have with national security so that we can get some oversight for that agency as well.
Thank you. And we go to Newsday, please.
Hi, good morning again. My question is to Dr. Siram Singh. The facilities finder app that you spoke about, do you have a timeline as to when it would be launched? And trying to sneak in a fourth question, could we get the statistics for the different counties, please? Thank you.
And we go to Mr. Siram Singh for response.
Yes, thank you very much. The facilities finder, it's a work in progress. It's almost completed, actually. There are a few minor things which we'd like to add to it to boost it and make it a little bit stronger and useful for the population. I wouldn't give a timeline at this point in time, but we'll get back to you on that. With respect to the statistics, I'll also get back to you on that. However, as you can see from the rates per 10,000 map, there are varying rates across the country. And you will see, if you look at the legend, there are different bands, so you could get an idea of what the rates are, what the statistics are per county using that. Thank you.
Okay, thank you very much. And we will, of course, send out these slides to the media post this media conference. We go to ACP News, please.
Hi, morning again. We have a report that there may be a shortage of tuberculosis drugs at the public health institutions. Is there any truth to that? Can you clear it up? Thanks.
No, normally Dr. Trotman, who is the medical director of the thoracic unit, will alert me to any shortages. She hasn't done so. I will check just to be on the safe side with my principal pharmacist as well as Dr. Trotman, but I have not heard of any such shortage in the country at this time.
Thank you very much. And we continue with the brief follow-up questions. Back to CNC3, please.
All right, Dr. Parashram, I just wanted to piggyback off of what Urvashi raised there, that issue of the illegal immigrants coming into the country. Are you concerned, and maybe Dr. Hines as well could weigh in on this, are you all concerned as the health practitioners at the fore of this COVID-19 fight that we may not be able to eradicate this virus at all from our country if this continue happening?
Yeah, so yeah, it is a concern. Always has been. If you have continuous introduction or reintroduction of a virus, it may be difficult to eradicate, but what we're trying to do, of course, is get it to the lowest possible level in the community. So I don't know if Dr. Hines wants to add anything.
I actually would. So I'm concerned about something different. My concern is that we continue to focus on probably the smallest source of introduction and spread and ignore the fact that the general population is our current source of COVID-19 cases. We keep going back to the reports of individuals breaching borders, and at this point, when we're in community spread, what we need to be more concerned about and more vigilant about is our day-to-day interactions, our day-to-day conduct with respect to managing our own respiratory illness, managing our own respiratory hygiene, and managing the adherence to our public health regulations, guidelines, and recommendations. So my concern is actually that we keep focusing on something that is probably the least of our worries at this point in time, and that we don't, in doing so, unduly and unnecessarily A, stigmatize a group of people, and B, distract from the more important source of illness. Every time someone asks, where is the illness coming from? It's coming from the population. People still have it. You can get it from somebody who is not displaying symptoms, but who had been exposed. So that's why we try to get people who have been exposed, even if they're not symptomatic, out of circulation. That's what quarantine is. You can get it from people who are having symptoms and who are moving around. That's why we ask people who are symptomatic not to move around, not to interact with other people, even within their households. So even if you're ill within your household, we are asking that when you have respiratory illness, you isolate yourself in your household from the other members of your household. So my concern is that we're looking a little too far afield at this point when the main source of our exposure is still our own local population. And I don't want us to move away from recognizing and dealing with that by approaching our public health adherence in the appropriate manner.
Thank you. And now to Newsday. I see you have a follow-up question.
Hi. So, oh dear, I think I forgot my question. Right, sorry. Following up on something that Prior asked, is there a shortage of pain medication in the country as well? Have you heard anything about that for conditions like lupus and fibromyalgia?
No, no. There's no shortage of pain medication at this point.
Okay, great. And I think we will take our last question now from TTT, please.
Yes, hi, good morning. Sonolala, TTT News. CMO, I think last week it was, there would have been a problem with blood coming into Tobago and stuff like that. Has this issue been sorted out, rectified?
Yeah, so I know Minister would have addressed the issue on Saturday, I believe. But yes, what they're doing is having significant blood drives in Tobago to try to get that situation rectified. I had spoken to the medical chief of staff, I believe it was on Saturday, who indicated that they are rectifying the situation with persons coming in and donating to their various areas in Tobago. So it is being rectified, albeit blood donation in Trinidad and Tobago has always been an issue, and we want to encourage persons to really come out and give voluntarily, because your blood is required to save lives in the country. We always have a shortfall, I would say, going back a couple decades. Well, there has always been a shortfall of demand outstripping supply in the way of blood banking.
Thank you. I do see that CNC3 had a follow-up question again. Mr. Khan? Okay, I think his signal.
Okay, all right. Hey, you hear me?
Yeah. Yes, we're hearing you.
Okay, just something off topic of COVID-19. About a month ago, there was an issue regarding, there was a bit of mix-up as to who was supposed to perform an autopsy on a body. I just wanted to know if you all had any updates on that, if the autopsy was eventually done.
Okay, I don't think we are sure of the issue you're talking about, but if you could provide us with some more details, we could look into it for you. All right?
Yes, Mr. Khan, you can send that to corporate communications and we will try to facilitate a response from CMO. And we have come to the end of this morning's media conference. Thank you to all participants. As we close, remember that together we can manage the COVID-19 pandemic. In the words of Leroy Calise, the Black Stallion, we can make it if we try, just a little harder. Protect yourselves and your loved ones. Practice physical distancing. Stay home if you are ill. Get your flu vaccine. And, of course, wear your mask.
COVID